It's really quite amazing when you stop and think about it. Our bodies have this incredible capacity to heal, to rebuild.
It really is.
And surgeons, well, they've been cleverly harnessing that power for a long time, using our own tissues to repair damage. Okay, let's unpack this a bit. Way back, 1944, Dr. Dos Santos did some foundational work using a vein as a patch in an artery.
Right, a patch graft.
And then soon after, Dr. Conlon really shifted things, didn't he? Using a reversed vein from the leg to bypass a blocked artery.
Yeah, that was a huge step. And those techniques, well, they were picked up and refined by giants like Doctors Linton and Darling. They really paved the way for modern vascular surgery.
It's fascinating how those early thinkers just knew somehow that using the body's own materials was the way to go.
Well, it makes sense, doesn't it?
Yeah.
Your body's much less likely to reject its own tissue. That's a huge advantage when you're rebuilding something as vital as a blood vessel.
Absolutely. And that brings us right to the core of our deep dive today. We're going to explore the world of autogenous vein grafts that's using your own veins specifically for treating blocked arteries in the legs.
Right. We call it inguinal revascularization, basically getting blood flow back down there.
Exactly. So our mission, if you will, for this deep dive is to really understand why, even with all the fancy synthetic materials we have now, using a patient's own vein is still, the gold standard for these critical procedures.
Yeah, we'll look at the different ways these vein grafts are put together, how they're handled, the really meticulous preparation they need, and crucially, what can make them fail down the road, because they don't always last forever.
Right. And for this exploration, we're leaning on some really solid sources, chapters from the 10th edition of Rutherford's Vascular Surgery and Endovascular Therapy.
The Bible of vascular surgery, pretty much.
Exactly. We're focusing on the sections about autogenous grafts and the very detailed techniques for harvesting those veins. So let's start with that big question. Why is your own vein still the top choice?
Well, Rutherford's makes it pretty clear. For patients dealing with claudication, that's pain when you walk, right? And especially for the more serious condition, chronic limb-threatening ischemia, or CLTI. Autogenous vein grafts they perform better. Consistently better outcomes compared to synthetic or prosthetic grafts.
And that's true whether the blockage is above or below the knee.
Both, above and below the knee. It really shows the body's preference for its own plumbing, you could say.
Yeah, nature knows best sometimes. And while the Great Saphenous Vein in the leg is often the star player,
Usually is, yeah.
it's interesting that other veins, like from your arm or the smaller saphenous vein in the leg, can also be used, right?
They can be alternatives, yes. But as the sources point out, the success rates can be a bit more variable. It really underlines why the Great Saphenous Vein, if it's available and healthy, is usually the primary go-to.
And connecting this back, Chapter 3 in Rutherford's talks about vessel wall biology.
Right, the fundamentals.
It delves into the anatomy, the histology, the microscopic structure, and the physiology, how these veins actually work. Understanding that biology helps you appreciate why these natural conduits often just function better than something artificial.
Exactly. It's not just a pipe. It's living tissue.
Okay, so before they even get to the operating room, there's a really crucial step: mapping out the patient's veins. This isn't a new idea, is it?
No, not at all. Preoperative assessment is absolutely key. Back in the 70s, they used venography, injecting dye, taking x-ray.
Right, I remember hearing about that.
But things really took a leap forward in the 80s with ultrasound.
Okay, so ultrasound duplex vein mapping, that's the standard now. What makes it so much better?
Oh, the advantages are huge. First, it's non-invasive. No needles, no radiation, nothing like that.
That's a big plus.
And it gives such a detailed picture. You see the vein's diameter, how deep it is, its exact location. Plus, and this is really important, it can spot problems.
Like what kind of problems?
Varicose veins, areas of scarring or fibrosis, any hardening from calcification, or if the vein has lots of big branches that might make it tricky to use.
So it's like giving the surgeon a detailed roadmap before they even pick up a scalpel.
Precisely, a blueprint. And the benefits aren't just about planning. Studies have actually shown that using this preoperative ultrasound mapping leads to lower rates of surgical site infections.
Really?
Yeah, fewer patients needing to be readmitted to the hospital, and it even saves money by avoiding unnecessary searching around during surgery to find a suitable vein.
Wow, that's a pretty significant impact from just doing an ultrasound beforehand. Now, the sources also mention CT angiography, CTA. How does that fit in?
CTA can also measure a vein diameter pretty reliably, and the measurements usually line up well with ultrasound.
Okay.
And often, Patients might already have a CTA scan done as part of evaluating their blocked arteries anyway. But while CTA is good at confirming the vein size, we call that good specificity, it's maybe less sensitive at picking up some of the subtle issues within the vein wall itself. So if the CT scan raises a question mark about the vein, they'll almost always follow up with an ultrasound for a closer look.
Got it. So ultrasound is still the workhorse, the primary tool for really checking out those veins. When they are measuring, where along the leg do they typically take these measurements?
Usually at multiple points, they'll measure high up in the thigh, near where the saphenous joins the deep femoral vein, then maybe mid-thigh, near the knee, upper calf, lower calf, all the way down towards the ankle.
So a whole profile of the vein.
Exactly. Gives them a really good sense of its size, whether it tapers significantly, and again, spots any of those tricky anatomical issues.
And I imagine there's a minimum size they're looking for, right? A target diameter.
There is. Yeah. And that's been debated and studied quite a bit. Big studies like PREVENT-3 and work by Wenger, Buth, and others, they've looked at this closely.
And what's the general consensus?
Generally, veins smaller than about, say, 3 to 3.5 millimeters in diameter, well, they've been linked to lower long-term patency rates.
Patency rate meaning how long the graft stays open and working.
Exactly. Smaller veins seem to have a higher chance of either clotting off or developing a narrowing, a stenosis over time.
So in most cases, bigger is better for vein size.
Generally, yes. But it's not an absolute cutoff, especially, when you're dealing with patients with really critical limb ischemia, CLTI, where maybe the options are limited.
Right.
Our sources point out that even smaller veins, maybe down to 2 millimeters, can sometimes be used. You can get acceptable results. But it often requires really close monitoring and being ready to intervene quickly if problems develop. And also, the in situ bypass technique, which we'll get to, seems to tolerate slightly smaller veins sometimes too. The bottom line is the best choice always depends on the individual patient, their specific blockages, and their unique vein anatomy.
Okay, so they've mapped it out, they found a suitable vein. Now comes the really delicate part, actually harvesting it, getting it ready for its new job as an artery bypass. Sounds like this needs a lot of care.
Oh, absolutely. Precise and crucially atraumatic dissection, handling it gently, is paramount. The #1 goal here is protecting the endothelial cells.
That's the inner lining of the vein.
Exactly. Think of it like the nonstick coating on a pan. It needs to stay smooth and intact. These cells are vital. They act as a barrier, they stop clots from forming, and they produce all sorts of beneficial factors that keep blood flowing nicely and the vessel healthy.
So what happens if those endothelial cells get damaged during the harvest? Why is that so bad for the graft?
Big problems. If you damage that lining, you expose the underlying tissue. That tissue is like a trigger for platelets to stick and start forming clots. And it also kicks off a whole cascade. It leads to the smooth muscle cells in the vein wall multiplying, producing scar tissue. You get inflammation. And all of this can eventually cause the graft to narrow or even block off completely.
So one little bit of damage can start a whole chain reaction.
Precisely. That's why techniques like the no-touch technique are so important.
No touch. Does that mean they literally don't touch it?
Well, not quite literally never, but it emphasizes minimizing direct handling with surgical instruments, like forceps. They carefully tie off the side branches a little distance away from the main vein wall to avoid pinching or damaging that main channel and its lining.
I see. Less direct handling, less chance of injury. Okay, so they've carefully got the vein out. What next? Do they check it before putting it in?
Yes, definitely. They need to gently infuse some fluid into the vein. We call this cannulation and distension.
Okay.
This lets them check its diameter, make sure there are no leaks from missed side branches, and identify any tight spots or bands of tissue squeezing it. But again, this distension has to be done really carefully.
Why is that? Too much pressure.
Exactly. Too much pressure can damage those endothelial cells we just talked about. Research shows pressures over about 100 millimeters of mercury can cause patchy endothelial damage. And if you go really high, like over 500 millimeter Hg, you can actually damage the deeper layers of the vein wall, the media, and mess with its structural properties. Even moderate overdistension can trigger unhelpful biological responses.
Is there a way to measure that pressure accurately?
There are devices, pressure manometers, that can monitor and limit the pressure, but honestly, they haven't become standard practice everywhere. It often relies on the surgeon's feel and experience.
So gentle handling is key all the way through. What about the fluid they use? What do they keep the vein in after it's out but before it goes in?
Good question. A few different solutions are used for this temporary storage. You've got crystalloids, basically sterile salt solutions like saline. Sometimes the patient's own blood is used, and then there are buffered solutions. These are designed to maintain the right chemical balance, the pH, inside the vein.
And does it matter which one they use?
It seems to. Studies, interestingly, have shown that using plain, unbuffered crystalloid solutions, like standard saline, can actually be quite harmful to the endothelium.
Really? Just simple saline?
Yeah. Buffered solutions, on the other hand, seem much better at preserving those crucial cells. There was a big study, Preoperative, mainly in coronary bypass, but relevant.
Okay.
It found that veins stored in a buffered solution had better patency rates, stayed open longer compared to veins stored in either saline or blood.
So buffered solutions seem like the way to go.
Based on the evidence, yes, buffered crystalloid looks like the best bet for short-term storage. But, actual practice still varies quite a bit from hospital to hospital.
What about temperature? Should the solution be cold or room temp?
That's another area where there isn't a totally definitive answer. There are theoretical arguments for both cold and room temperature storage. But practically speaking, maintaining a consistently cold solution in a busy operating room can be tricky. So most surgeons tend to prefer using room temperature solutions just for practicality. There's no strong recommendation either way.
Makes sense logistically. Now, heparin that's used to prevent clots, right? Is that added to these solutions?
Yes, absolutely. Unfractionated heparin is pretty much universally added to the harvest and storage solutions. The goal is to stop tiny clots, microthrombi, or fibrin deposits from forming inside the vein before it gets implanted.
Okay.
They usually use concentrations around 4 to 10 units per milliliter.
And are there any other drugs they might add, maybe to stop the vein from spasming or protect it further?
Yes, pharmacologic agents are often used. 2 main goals: prevent vasospasm, that's the vein clamping down, and help maintain that endothelial integrity.
Okay, like what?
Papaverine is probably the most studied vasodilator for this. It can be injected around the vein even before harvesting, though that's tricky. More commonly, it's applied to the tissues around the vein and added to the distension and storage fluid.
And does it help?
Studies generally show it does. Less endothelial injury compared to controls where it wasn't used.
Interesting. Anything else?
Yeah. Another approach uses a combination of glycerol trinitrate, that's like nitroglycerin and verapamil, a calcium channel blocker.
Okay.
Some head-to-head comparisons actually suggest this combo might be even better than papaverine alone at preserving that endothelial layer. But, despite all this research into optimizing how we handle these veins, the sources emphasize there's still no single, universally agreed upon best protocol. Different centers do things slightly differently.
And didn't you mention a trial where they tried a drug to stop the cells growing inside the graft? Etoflagid?
Right, that was the Preoperative trial. Etoflagid was designed to block a specific pathway involved in cell growth, the idea being to prevent that intimal hyperplasia thickening.
And did it work?
Unfortunately, no. It didn't show a significant improvement in how long the vein grafts stayed open, either in leg bypasses or coronary bypasses. That was a bit of a surprise and kind of forced a rethink of some of the basic ideas about preventing graft failure.
So, still very much an active area of research and refinement. Okay, let's shift gears. How do they actually get the vein out? I know the traditional way is one long cut.
Yeah, the traditional single continuous incision. It works, but it definitely has downsides. Wound infections, the wound breaking down.
Yeah.
These aren't uncommon and can really complicate recovery.
Right, so they developed less invasive ways.
Exactly, trying to reduce the incision length and hopefully lower those wound complication rates.
What came first?
One of the earlier steps was using skip incisions, making several smaller, separate cuts along the path of the vein instead of one long one.
Okay.
And studies did show that this improved wound healing compared to the long incision.
And then came endoscopy, like keyhole surgery.
Pretty much. With small cameras, specialized instruments, you can do the harvest through just 2 or 3 tiny incisions.
How does that work?
Through these small ports, the surgeon uses tools to see the vein, find the side branches, clip or tie them off, then tie off the main vein at the top and bottom, and carefully pull it out through one of the small incisions. Maybe an extra tiny cut here or there if needed.
I know endoscopic harvest is really common for heart bypasses now. Is it used as much for leg bypasses?
Not quite as much, no. There are a few reasons. Leg bypasses often need much longer pieces of vein. And the endoscopic technique definitely has a steeper learning curve. It takes quite a bit of practice to get really good at it.
Right.
Plus, there were initial worries. Maybe all that extra handling of the vein with the instruments, even through small holes, could cause more damage to that inner lining.
Did that turn out to be true?
Well, in the cardiac surgery world, most studies looking closely at the vein tissue afterwards and at the clinical outcomes haven't generally shown significant differences in vein injury or graft patency compared to open harvesting.
Okay, so for heart surgery, it seems comparable. What about for the legs, for peripheral bypass?
The results there have been, well, more mixed. Some centers that do a lot of endoscopic harvest for leg bypass report good results, fewer wound problems, similar graft patency.
But not everyone agrees.
No. Other studies, including some large database analyses like from the Vascular Quality Initiative and meta-analyses combining multiple studies, they've actually suggested that endoscopically harvested grafts might have slightly lower primary patency rates.
Lower rates of staying open.
Yes, and maybe without a clear benefit in reducing surgical site infections in the peripheral setting, unlike in cardiac.
That sounds like a potential trade-off then.
It's something surgeons weigh up.
Yeah.
And that learning curve is a big factor. Some estimates say it can take up to 100 cases to really master the endoscopic technique for long leg veins.
Wow, that's a lot.
Yeah, and there are upfront costs for the equipment too, though proponents argue that might be offset by shorter hospital stays or fewer readmissions for wound problems down the line.
So what's the bottom line on endoscopic versus open for leg veins?
The evidence isn't definitively saying one is always better than the other for peripheral bypass. It seems that in experienced hands, the outcomes with endoscopic harvest can be comparable to open, but it's not universally adopted, and open or skip incision techniques are still very common.
Okay, so they've got the vein out one way or another. Now, how do they actually configure it to bypass the blockage? You mentioned different ways they can orient it.
Right. There are three main configurations: reversed vein grafts, non-reversed vein grafts, and in situ vein grafts.
Let's start with reversed. Sounds
Yeah.
like the simplest.
It often is, conceptually. You take the vein out, flip it end for end, and sew it in. The one-way valves inside the vein are still there, but since the blood flow is now going the opposite way...
They just get pushed open.
Exactly. They shouldn't block the arterial flow. The potential downside, though, is that veins naturally taper. They usually get smaller the further down the leg you go.
Right.
So when you reverse it, the originally smaller distal end gets sewn to the often larger artery proximally, and the originally wider proximal end goes down to the smaller artery distally. This can create a size mismatch,
Where's the mismatch usually most problematic?
particularly at the distal anastomosis, connecting to the smaller artery. Also, the proximal part of the graft, the upper end, seems to be a common spot for narrowings to develop later, and if you start with a smaller vein segment there because of the reversal, it might worsen that tendency.
Okay, so that natural taper can cause issues with reversed grafts. Is that where non-reversed grafts come in?
Precisely. If there's a really significant taper in the vein or a big size mismatch between the inflow and outflow arteries, a non-reverse configuration might be better.
So how does that work?
You still take the vein out completely, but then you have to do something about the valves because now the arterial blood flow would be going against them. So you have to lyse the valves, basically destroy them or render them incompetent. Once the valves are dealt with, you sew the vein in keeping its original orientation. The end that was originally higher up stays higher up.
That sounds like more manipulation, having to destroy all those valves. Does that risk damaging the vein more?
It definitely involves more handling during the valve lysis process, yes. That's a potential drawback. However, some argue there might be benefits to getting rid of the valves.
Benefits? How so?
Well, those valves, while not a big deal in the low-pressure venous system, can potentially cause issues in the high-pressure pulsatile arterial system. They can create turbulence, areas where blood flow might stagnate.
Okay.
Studies have shown that lysing the valves can actually decrease resistance and increase blood flow through the graft by maybe 15–30%. Plus, there's a theory that intact valves might act as a starting point, a nidus, for that intimal hyperplasia thickening we talked about.
So destroying the valves might actually be good hemodynamically.
Potentially. Although, studies looking at valve sites specifically haven't shown they commonly progress to critical stenosis. Many changes actually regress. But the main drivers for choosing non-reversed are usually that significant vein taper and the size mismatch issue, trying to get a better size match at both ends.
Okay, that makes sense. And the third type, in situ. That sounds like leaving it where it is.
That's the core idea, pioneered by Rob's group way back. You only mobilize the very top and bottom ends of the Great Saphenous Vein enough to sew them to the artery. The main length of the vein stays in its natural bed under the skin.
But you still have to deal with valves and branches.
Absolutely. 3 key steps. mobilize the ends for the connections, anastomoses, remove or disable all the valves along its length so arterial blood can flow down, and interrupt all the side branches.
Why interrupt the branches?
Because otherwise the high-pressure arterial blood would flow out through those branches into the surrounding veins, creating arteriovenous fistulas and basically stealing flow away from where you want it to go down the leg.
I remember reading the early ways of dealing with the valves for in situ were a bit rough.
They were. Involved multiple cuts along the vein, more trauma. But then came much better instruments, valvulotomes, designed specifically for lysing the valves through small access points.
Ah, that made it more feasible.
Exactly. It allowed for less manipulation, maybe better preservation of the vasa vasorum, the tiny blood vessels feeding the vein wall itself.
Right.
And big studies, like one from Shah's group, showed excellent long-term patency and limb salvage with in situ grafts. Contemporary comparisons generally show no significant difference in long-term outcomes compared to reversed or non-reversed grafts.
Good to know. So once they've decided on the configuration, where exactly do they make the connections, the anastomoses? Let's start at the top, the inflow.
The common femoral artery, the CFA, in the groin, is the most frequent inflow site. How exactly you construct that top connection depends a bit on where the saphenous vein naturally joins the femoral vein, the saphenofemoral junction. You mobilize the top end of the saphenous, temporarily clamp the femoral vein, divide the saphenous, and repair the femoral vein opening. Sometimes that very first valve in the saphenous can be tricky to reach with standard tools, so they might briefly turn that bit inside out to cut the valve under direct vision.
What if the femoral artery itself is diseased?
Good point. If there's significant plaque right there, you might need to make the connection higher up on the external iliac artery. Or sometimes use a little patch of another vein to widen the opening, or do an endarterectomy, clean out the plaque from the artery, or even replace that bit of artery with a small synthetic graft first.
Can they use other arteries for inflow if the CFA is okay?
Sure, if the proximal disease isn't the main issue, they can originate the bypass from the superficial femoral artery, SFA, the profunda femoris artery, PFA, or even the popliteal artery behind the knee sometimes.
Okay, that's the inflow. What about the other end, the outflow, down the leg?
Downstream, the easiest targets are usually the tibial arteries, the posterior tibial, the peroneal, and the dorsalis pedis artery on top of the foot. You can reach them relatively easily.
What about the popliteal artery below the knee?
That can be used, but especially with in situ grafts, the angle where the graft meets the artery can sometimes be quite sharp, almost 90 degrees, which isn't ideal for flow. Careful tunneling of the graft might help create a smoother angle.
And the popliteal above the knee.
That's usually an easier connection geometrically, less of an angle issue.
Yeah.
But if you're doing an in situ graft to the above knee popliteal, the actual in situ segment might end up being quite short, which might negate some of the theoretical benefits of leaving the vein in its bed.
Let's just circle back quickly to the valve lysis destroying the valves in non-reverse or in situ grafts. You mentioned different types of valvulotomes. Can you recap the main kinds?
Sure, they've evolved quite a bit.
Yeah.
Generally, you can group the current ones into 3 types: modified mills, valvulotomes, ejectable or expandable ones, and fixed diameter ones.
Okay, the modified mills.
That's a thin, flexible instrument, often inserted through a side branch. You advance it past the valve, gently distend the vein so the leaflets close, and then as you pull it back, a tiny blade on the tip catches and cuts the leaflet edge. Might need a couple of passes.
Delicate work. The adjustable type, like the lamator.
Right. That has cutting blades housed in self-centering wire hoops. You advance it, deploy the blades so they expand against the vein wall, and as you withdraw it, the blades cut the leaflets, adjusting to the vein's diameter.
And the fixed ones?
These are more direct. They have detachable cutting heads of different fixed sizes, say 2, 3, 4 millimeters. You pick the right size head, attack it, insert it, and give it a controlled, rapid pull. The sharp edge cuts the leaflets.
So different ways to slice the valve, basically. Do they all work equally well?
Studies looking inside the vein afterwards show they all achieve complete valve disruption, most of the time, maybe 70 to 95% effectiveness. Though maybe slightly less complete disruption up near the top end of the graft sometimes.
And does one type lead to better graft survival?
Interestingly, no. Direct comparisons haven't really shown any significant difference in long-term patency rates based on which type of valvulotome was used. Seems they all get the job done adequately.
Good to know. Now, for those in situ grafts where the vein stays put, you mentioned needing to deal with the side branches. How do they do that without exposing the whole vein?
Right, that's key. You have to stop flow going out those side branches. The traditional open in situ approach involves that long incision, making it easy to see and tie off all the branches. But, as we said, more wound issues.
So what are the less invasive options for finding the branches?
They've tried various things: intraoperative venography, dye and X-ray, or duplex scanning during the operation. But honestly, they can be pretty inaccurate, sometimes missing nearly half the significant branches.
Really? That many?
Yeah, things like angioscopy, putting a camera inside the vein, or transcutaneous illumination shining a bright light through the skin seem a bit better, maybe finding about 2/3 of them.
Does missing some branches affect how long the graft lasts?
It seems graft patency isn't hugely affected whether you use a full open incision or skip incisions to ligate branches. However, the techniques that rely more on those less direct, semi-closed methods for finding branches do seem to have a higher rate of persistent arteriovenous fistulae afterward.
Those unwanted AV connections, are they always a big problem? Do they always need fixing?
That's debated. The traditional teaching was, yes, ligate them all if they persist. But maybe a more conservative approach is okay sometimes.
How so?
Well, studies show about a third of these persistent fistulae might close on their own over time. Another third might eventually need revision if they're clearly stealing significant flow. But the last third might just stay there, stable, and not cause any major problems.
Yeah.
So aggressively chasing every single one is maybe not always necessary.
Interesting. Okay, we've focused heavily on the Great Saphenous Vein, but what if it's just not available or not good quality? What other autogenous options are there?
Arm veins are a really important backup. The team at Beth Israel Deaconess in Boston has published a lot on using arm vein for leg bypasses.
So you need to check the arm veins carefully first, too.
Absolutely. Preoperative duplex ultrasound of the upper extremity veins is crucial. You might use a single long piece, ideally, or sometimes create a composite, like using the median cubital vein at the elbow to connect the cephalic and basilic veins into a loop.
Are there downsides to using arm veins?
One potential issue is damage from previous IVs or blood draws iatrogenic injury, especially in those superficial veins like the cephalic and the forearm. Angioscopy can be useful here to really assess the quality inside the vein. Rutherford's actually has a good figure summarizing the pros and cons of different arm vein segments.
What about the small saphenous vein, the one up the back of the calf?
Yep, the SSV. It's shorter, runs from the ankle up usually to the popliteal vein. It can be used, often in composite grafts, but sometimes as a single segment for shorter bypasses. Again, need a preoperative duplex, looking for at least 3 mm diameter.
Is it easy to get to?
It's generally considered the third choice, partly because the harvest can be trickier, it's deeper, sometimes under the fascia might need a specific posterior incision, but it can be useful for in situ bypasses to tibial arteries using that posterior approach, with decent patency reported. Though as part of a composite graft, its durability might be less impressive.
I also recall reading about using deeper leg veins, like the femoral vein itself.
Yes, the femoral popliteal vein. It was studied as a primary option. A randomized trial actually showed similar 5-year patency and limb salvage compared to saphenous vein.
So why isn't it used more?
The main issue was more long-term problems in the donor leg swelling, signs of venous blockage. So the conclusion was saphenous vein is still preferred if available.
And using arteries, like the superficial femoral artery.
If a segment of the SFA is blocked, you can sometimes do an aversion and darterectomy, clean it out, and use that cleaned out artery segment as a short graft, maybe part of a composite.
Yep.
But they have a high risk of rupture if used in infected areas, and the patency rates when used with vein haven't been great, often failing from sudden clots.
Lastly, the hypogastric artery from the pelvis.
Right. It can be a source for short grafts within the abdomen, like in complex aortic repairs, because it has branches good for multiple connections and there's usually good collateral flow, used sometimes in adults. But it's actually a primary choice for kidney artery repairs in kids, because vein grafts in kids can dilate too much later on. Not a lot of hard data on long-term patency in adults, but used anecdotally in specific situations.
Okay, a whole range of backup options, each with pros and cons. We've covered selection, harvest, configuration, connection. Now let's tackle the tough part, graft failure. The sources break it down into early, midterm, and late.
That's right. Early is usually within the first 30 days. Midterm is roughly 30 days to 2 years. And late is anything after 2 years.
And the causes are generally different for each period.
Generally, yes. Early failure often points to a technical problem during the surgery. Midterm failure is typically blamed on intimal hyperplasia, that thickening of the inner lining. And late failure is often due to the progression of atherosclerosis, either in the native arteries or the graft itself.
Okay, let's dig into early failure first. What kinds of technical issues are we talking about?
These happen in maybe 5% of cases, usually fall into 4 buckets. Inadequate inflow, not enough blood getting to the graft. Inadequate outflow problems with blood getting out of the graft distally. Extrinsic issues, things outside the graft, like kinking, compression, or the patient being hypercoagulable, clotting too easily. And intrinsic problems, actual defects within the graft itself.
Can you give examples of those intrinsic problems?
Sure. Could be damage to the endothelium during harvest, a retained valve leaflet that didn't get laced properly, an intimal flap or tear created during handling, a misplaced suture at an anastomosis, using a vein that was just too small, or even pre-existing disease like sclerosis or calcification in the vein segment used.
What happens if a graft fails early?
Usually it means a trip back to the OR for exploration and revision. If they can identify and fix the problem, the outcomes after revision can actually be pretty good long-term.
Okay. Now, midterm failure, this intimal hyperplasia, sounds like a biological response gone wrong.
It really is. The vein, remember, is used to low pressure, steady flow. Suddenly it's hit with high arterial pressure, pulsatile flow, plus the trauma of surgery itself. This combination triggers a whole cascade.
What happens biologically?
The vein wall releases signaling molecules, cytokines, growth factors. These recruit inflammatory cells. Then the smooth muscle cells in the vein wall sort of change their job description. They de-differentiate, start multiplying, and migrate into the intima, that inner layer.
And that causes the narrowing.
Exactly. They pile up in the intima and produce extracellular matrix, basically scar tissue. This thickens the intima, narrows the lumen, restricts blood flow, and eventually can lead to thrombosis, clotting off the graft.
So the body's attempt to heal and adapt actually causes the blockage.
In a way, yes. It's an overzealous repair response.
Thought.
Interestingly, this thickening isn't usually uniform along the whole graft. It tends to be focal, often near the anastomosis, the connection points, or sometimes in the midgraft.
Does it happen at the old valve sites?
It can, but studies suggest severe stenosis right at valve sites is actually rare. Advanced imaging like CTA shows the remodeling is pretty complex and dynamic. Factors like the patient's race, the initial vein diameter, they seem to influence whether the graft tends to narrow or even sometimes widen over time. It's complicated, involves local trauma, hemodynamics, individual repair capacity, lots of factors.
And then late failure after 2 years. Is that just atherosclerosis catching up?
Often, yes. It can be progression of disease in the inflow or outflow arteries around the graft. Or atherosclerosis can develop within the vein graft itself over time.
Do we know much about atherosclerosis in vein grafts?
A lot of what we know comes from coronary bypass grafts looked at after death. They often show fibrous tissue, lipid-filled macrophages, immune cells, calcification. Looks quite similar to regular atherosclerosis. Vein wall degeneration leading to clot formation, like plaque rupture, can also happen.
Does cholesterol medication help vein grafts?
It seems to for coronary grafts. Lipid-lowering therapy improves their patency. Studies on peripheral vein grafts that failed late have also found atherosclerotic changes, although some reports also point to ongoing fibrocellular hyperplasia as a cause of late failure too. It might be a mix.
Is there a link between the early hyperplasia and later atherosclerosis?
That's been speculated. Maybe the early changes set the stage for later atherosclerosis, but it's still mostly theory. The key takeaway for late failure is the importance of ongoing surveillance to catch problems before a graft clots off completely.
Given these failure modes, especially the midterm hyperplasia, were there attempts to maybe treat the vein graft during surgery to prevent this? Like with that drug etofolaget you mentioned?
Exactly. There was a lot of hope placed on intervening early. The idea was if you could stop that initial burst of smooth muscle cell proliferation right after surgery, maybe you could prevent the later stenosis.
So etofolaget targeted that?
Yes. It inhibits something called E2F, which is crucial for cell cycle progression. Looked promising in the lab. But as we said, the two big phase 3 trials, one in leg bypasses and one in coronary bypasses.
It didn't work out.
Right. No significant clinical benefit in improving graft durability. It was a setback and really forced a reevaluation of that whole strategy. The biology is clearly more complex than just stopping one pathway.
So the hunt for the magic bullet to make grafts last forever continues. Okay, shifting back to assessment. How do surgeons check the graft during the operation right after they've finished sewing it in?
The first check is usually simple. Visually inspect the graft in the anastomosis, feel for a pulse downstream, listen with a handheld Doppler, basic stuff.
And if that seems okay?
If everything feels and looks good, some surgeons might stop there. But if anything seems suboptimal, or even routinely in some centers, they'll do a more detailed assessment.
Like what?
Most commonly, completion angiography. injecting contrast dye, and taking an X-ray picture to see the flow through the bypass. Intraoperative duplex scanning, using ultrasound right there on the table, is also becoming more common.
Is it better to check every graft with imaging or only if there's a concern?
That's still debated. There's no solid consensus that routine completion imaging on every case significantly improves overall outcomes compared to being selective. Practice varies.
Are there other ways to check it intraoperatively?
Yeah, a few others are sometimes used. Angioscopy, camera inside, intravascular ultrasound, IVUS, measuring pressure gradients across the graft, plethysmography to assess limb blood flow, transcutaneous oxygen measurements. Various tools are available.
Okay. And then after surgery, when the patient goes home, how are these grafts monitored long term? You mentioned surveillance.
Right, because even a perfect vein graft isn't guaranteed to last forever. Surveillance is crucial to try and catch problems before the graft fails completely, when it might still be salvageable.
What does surveillance involve?
It's a combination of things. Regular clinic visits, asking the patient about symptoms, any return of claudication, new rest pain, physical exam checking pulses carefully, and measuring the ankle brachial index, the ABI.
Remind us about the ABI goal.
Ideally, post-op ABI should be over zero 0.9, or at least 0.15 higher than it was before surgery. A significant drop in ABI later on, usually more than 0.15, is a red flag.
And ultrasound, duplex scanning.
Yes. Duplex ultrasound is a cornerstone of most surveillance protocols. It lets you visualize the graft directly, look for narrowings, and measure blood flow velocities.
What velocities are they looking for?
Normal peak systolic velocity, PSV, in a graft is usually above 45 centimeters a second. If they find a spot with much higher velocity, they calculate a velocity ratio comparing the speed in the stenosis to the speed just before it. High ratios, like over 3.5, or very high peak velocities, over 300 centimeters sec, indicate a severe stenosis. Or if the flow throughout the whole graft drops below 45 centimeters sec, that's also concerning.
Does adding routine duplex scans actually improve outcomes compared to just clinical checks and ABI?
That's where the evidence gets a bit murky. Some studies suggest duplex surveillance leads to better assisted patency, meaning they find and fix problems before the graft clots. But other studies haven't found a significant difference in overall graft patency, limb salvage, or even mortality when comparing intensive duplex surveillance versus just clinical ABI follow-up.
So the jury's still out on how much extra benefit duplex adds.
The Society for Vascular Surgery guidelines actually rate the evidence supporting routine duplex surveillance as relatively low quality. But because it's non-invasive and can potentially detect problems early, they still recommend a schedule of clinical exam, ABI, and duplex ultrasound post-operatively, maybe at 1, 3, 6, 12 months, and then annually thereafter.
What about medications after bypass? Blood thinners.
Again, limited high-quality evidence for the ideal antithrombotic regimen. Data from the VQI registry didn't show a benefit for oral anticoagulants like warfarin for grafts below the knee. The current SVS recommendation is generally antiplatelet therapy, like aspirin or clopidogrel, for most patients, without routine anticoagulation unless there's another specific reason for it.
Wow. Okay, we have definitely taken a very deep dive today into this incredibly complex area of autogenous vein grafts.
We really have.
It's just so clear that while using the patient's own vein is still, the top choice for these bypasses, there's just so much that goes into it. The meticulous planning, the super careful surgical technique, the ongoing monitoring, it all has to come together.
It really does. And what's truly remarkable, I think, is seeing how the body responds to all this. It highlights this really intricate dance between the surgeon's skill, our growing understanding of vascular biology, and just how vital that long-term surveillance is for making these repairs last as long as possible.
It absolutely makes you think, given all this complexity, the body's dynamic responses, what's next? What are the future possibilities for making these repairs even more personalized, even more durable, using our own tissues?
Yeah, feels like there's still so much potential there, doesn't it? Pushing the boundaries further.
Definitely food for thought. And for anyone listening who really wants to get into the nitty-gritty of any specific aspect we touched on today, the mapping, the harvest techniques, the failure modes, we absolutely recommend checking out those detailed references and chapters in Rutherford's vascular surgery text. It's all in there.